All right, Dr. Rogers, well, you have the show is yours now. So go ahead and introduce yourself and have at it.
Okay, yeah, well, I will go ahead and I guess start sharing my screen. And see if this works. So my name is Cody Rogers. Everyone, I don't know, maybe there's someone in the audience that I've met, but I'm a family medicine trained hospital doctor down in Cox Springs, and I actually have kind of a weird position because I work only at night as opposed to during the daytime. Let's see. Yeah, so here's my slide set. And I will caveat too, I'm a little bit under the weather, and so I may be taking pauses to drink from some water I have here during the talk. So forgive me for that. But I did want to talk about atrial fibrillation today. So these are kind of the objectives here. I want us to be able to understand kind of the basic pathophys, what a patient with atrial fibrillation will show up looking like, and what we need to do about it, and kind of identify some risk factors and whatnot associated with the atrial fibrillation, and be able to look at any EKG and find it. So, and then, yeah, there a little bit just kind of talking about culture and how that can affect how information is passed on in medicine and how we need to think about that as well. So just a little bit of that there at the end. So a couple disclaimers, kind of your typical stuff. Don't have any relevant financial conflicts of interest. A couple other more specific things. I'm not a cardiologist, so like I mentioned, I'm family medicine trained. I work just as a hospitalist right now, and so there are probably some nuance and some deeper levels of information that I won't be able to supply to you just because I don't have the training. But if you have questions about anything or want to go deeper, then feel free to ask, and we can try and find an answer together. Or later on, I'll have my contact information at the end. So if you want to, you're welcome to reach out and we can try to find an answer. I do want to just kind of caveat too that I love Jesus, and I think that's an important part of what I do, like in my day-to-day, and how that affects my life. And so just something I want you guys to know too. And then last disclaimer, this was a statement made by someone in my one of my attendings when I was in medical school. He said, "Nothing in medicine is ever 100%, not even that statement I just made." And so just kind of the thought there that there's we're going to talk about some different things, and kind of it's going to be presented a little bit black and white, but for the most part in medicine, there's just a lot of gray area, a lot of overlap, a lot of stuff that can go either way. And so again, I think like in college and some of the degrees that we get, there's a lot of just kind of stuff presented black and white. It's a little bit of an ivory tower. In med school, it kind of gets, you see that there's a little bit of gray, like these answers are all correct. This one is the most correct, but any of these are okay. And then when you get out in practice, it's kind of like dealing with real people. It's just kind of gets a lot more grayer. So just something to think about too. And I guess I should ask, can you guys see the slides okay? And hear me okay? You guys over there at the AHEC and everywhere?
I can.
Okay. You guys can see the slides okay too?
Yep.
Perfect. Okay. So, okay, well, let's jump in. I do think it's helpful to learn from cases. So I'm going to present a little bit of a case here, and we'll try to get a little bit of audience participation, so to speak. We'll see how that goes with the video. So this is a real patient that I saw down in Branson. So a 62-year-old male presents with shortness of breath and syncope. So he had passed out at home. So that's very limited information. All I'm going to give you right now, I would love if you guys would just kind of shout out or mention some possible things that could cause that.
Anemia.
Anemia, perfect.
Acute coronary syndrome.
Sure, perfect.
EE.
Aortic stenosis.
Sure. Other thoughts? No wrong answers. This is very limited information, and so it'd be very hard pressed to say something that might not cause these. Yeah, so Sounds good. All right. Well, so this was a little bit of the differential that I came up with. Did not have, don't guess I had an email in there, so it was a good addition. But a lot of different things can cause shortness of breath, as you guys know. A lot of different things can cause passing out. So, and sometimes, I mean, you can have multiple different things leading to either of those events or both of those events. And so that was kind of the initial differential I was thinking as I was seeing the patient. So a little bit more information. He's had, excuse me, he's had about 2 episodes of the passing out. He thinks that he gets more dizzy, lightheaded with standing up. He's not really sure. Kind of getting into that gray area like we were talking about. It's been going on for about 2 days. He has a slight ache in his chest. He said it's not severe. Made a big deal saying it's not pain per se, but he's got an ache that's in his central chest. Does not have a cough, doesn't have a fever, no headache, numbness, tingling, so focal neurologic deficits. So right there, just kind of with that information, some things are starting to, I guess, have a higher pretest probability of being present as opposed to absent. So I will keep moving forward. Medical problems that he has diabetes, which again raises the risk of some of those. Hypertension, he's got chronic septic arthritis, which was a little bit strange. So he's on daily amoxicillin for that. And you can see some of the other medicines he takes, glipizide, some blood pressure medicines, metformin. Let's see. Oh yeah, surgical history. He's got a left knee arthroplasty and appendectomy. So doesn't use drugs. He does smoke 3 beers a month. So again, just a little bit more information. Again, kind of looking at all the history together. So I mean, the fact that he has diabetes, takes glipizide, that could lead to hypoglycemia. Metformin typically doesn't. Could be orthostatic if his blood pressure medicine is kind of dosed too high, especially with the metoprolol on board. He's a smoker. No, I'm sorry, he's not a smoker. So COPD seems less likely generally at this point, but some of those other things are possible. So a little bit more information, kind of presentation of vital signs. And there's a lot here, and I don't know that we need to just read through everything, but looking just at the vital signs up here, anything stick out to you guys? That can be a little bit rhetorical, but it's kind of looking at that. The most obvious abnormal thing is that his heart rate is 142, and that's pretty elevated. And then listening to his heart, there's no murmur. His rhythm though is irregular and it's fast, so that kind of gets your mind thinking on something specific too. So diagnostics, as far as what we actually did, his chest x-ray was normal, so that makes pneumonia less likely, and maybe significant fluid overload from heart failure unlikely. CT head was normal. He got a CT head because he had the episode of passing out, may have hit his head, so reasonable. Labs showed a bump in his creatinine, so it's pretty elevated there. His TSH is a little bit elevated, and then D-dimer is, for his age, actually also elevated. And so let's see, got an EKG on him too, and so this is his actual EKG. Yeah, and so this kind of answers the question of what's going on, at least part of what's going on. And we'll talk a little bit more about how to interpret this later on. But if there's anybody that's spent time in the hospital or spent time rotating, where you look at EKGs, it's honestly, it's really important to kind of look through, be very systematic about it. And so what I like to do, are y'all able to see the mouse when I like move over?
Yes.
Okay, perfect. So I like to start. So a couple different things you want to look at. You want to first make sure it's the right patient and the right EKG that you're looking at. This is because this is the only one we have right now. And then I like to, again, be systematic, look at an AVF here to kind of see if the axis of the heart is in the right place. And so if they're both positive, so one is positive, it's mostly positive, it's above this baseline, and then AVF is less positive, but seems generally more positive than negative. Again, looking at the baseline and what's above or below it. And so the axis is in the correct place. And then I'll try to look at the heart rate. And there's different ways to do that too. And it's sometimes gets harder if it's irregular, which this one is irregular. But I do the find where QRS is on the line and then count 300, 150, et cetera. So he's about, let's see, so 300, 150. So he's about upper 140s maybe, which I think is what his heart rate actually was. And then looking at the PQRS and ST areas. So looking for P waves, I actually don't see any. And we'll talk about, again, a little bit more about what those look like and finding them on the EKG, but I don't see any P waves, which is, again, pretty helpful for knowing what's going on, at least with his rhythm. His QRS complex looks okay. I don't see anything real significant there in any of the leads. And then the ST segment, the T waves, those also look fine. There's no significant depression or elevation. There's a little bit of artifact, I think, in B2. So it looks weird, but I think that's just artifact. All right. So again, a little bit of a rhetorical question, but this is kind of what we're facing now. And this is what we're going to talk about some too. The fact that he has atrial fibrillation and he's got rapid ventricular response. And so, yeah, we'll talk about what we should do with that. So this is kind of, we'll come back and hit on these things, but this I feel like is a good representative case of atrial fibrillation. So down in the ER, he was started on a diltiazem drip. He probably got a diltiazem bolus too. He was started on a heparin drip as well down in the ER, and those were continued at least for the night when I saw him. And then he converted to sinus rhythm. He was discharged home on oral diltiazem, on Eliquis, which is Pixaban, and diltiazem, I should say, is cardizem, is the other name for that. And he was sent home on a Zeo patch, which is a pretty handy device. He had outpatient follow-up with cardiology, had a negative stress test. He was found to have sleep apnea on further studying, so he was started on a CPAP, which again, representative for someone who's got atrial fibrillation. So yeah, so we'll kind of talk about the ins and outs of these things here and why these were used as opposed to something else, and we'll just get right into it. So a little bit of a twist, I'm going to throw something else at you, and this is kind of circling back more to the kind of our cultural competency and what's involved in that. So imagine the same patient, and I'm 62-year-old male with shortness of breath and syncope. So we actually didn't talk much about his ethnicity or potential cultural things in that first presentation. But let's say that he's accompanied by an adult daughter who speaks for the patient. She's kind of taking over the role of interpreter. And his EMR, in the EMR, it says that his primary preferred language is Spanish. And this is something that you just see in the chart before you go see him. And so you call down at the ER and they say, oh, he's got a daughter in the room who's doing the translating, but he speaks Spanish. He doesn't really speak English at all. Now, a little bit different question of what would you do as far as trying to make your discussion and your treatment of this patient culturally relevant, more culturally relevant. So something else we will talk a little bit about kind of later on here. But I want you guys to think about that. So jumping back into kind of discussions about AFib, and I'll try not to just read off the slides. And I think I've sent these on to Ms. Tricia, so she'll be able to get these to you guys as well. There's kind of, a couple different ways to think about atrial fibrillation, but really it's just kind of disordered electricity, I think, is the simplest, easiest definition. And we'll actually kind of jump over here and we'll jump back to the other slide in a second. But you guys probably remember, you probably remember better than I do because you're a lot closer to learning it, but generation of electricity through the heart that causes depolarization and causes the actual contraction of the heart muscles. It starts in the sinoatrial node up here, kind of spreads through the atria. That causes the P wave on the QRS complex. Then it kind of gets transferred through the AV node, and that spreads it through the ventricles, like with the Purkinje fibers and bundle of his and all that. And that's usually a very ordered, very it's just very rhythmic, done very well, et cetera, et cetera. And so that produces kind of these typical changes on the QR, on the EKG that you see. So you see a nice T wave as the atria contracts, whereas complex from the depolarization of the ventricles and the contraction there, and the T wave is the large ventricles recover. Then if you have atrial fibrillation, effectively what is happening is that there's like a bunch of irritated foci of depolarization in the atria, and so they'll cancel each other out, or kind of mess each other up, but you won't get a good depolarization of the atria going through, which means you won't get a P wave because that electrical event is not occurring, and then you also not get steady rhythmic activation of the AV node, leading to the regular depolarization and contraction of the ventricles. And so that's kind of the basic problem. And usually kind of what I tell patients, I hold up my hands and I use my left hand and say, like, the top part of your heart is just kind of wiggling, it's not beating very hard, and the bottom part takes over and it beats too fast, and it causes all these problems like passing out, like chest pain, like shortness of breath that patients present with. So try to make it a little bit, and that's the top part vibrates, the bottom part takes over. That's my kind of more simple explanation to patients so that they have a better idea of what's going on with their heart. That's kind of what's going on with it. A couple definitions. So you'll hear valvular, and that's just associated with mitral stenosis, high risk of stroke. There's other things that can lead to a higher risk of stroke that's kind of newer being studied as far as the size of your atria. Like if they're enlarged, if there's higher pressure in your atria, then they think that there may be a higher risk of stroke with that sort of a person with atrial fibrillation with that phenotype also. And persistent versus paroxysmal, you can probably imagine persistent is just, it hangs around. The person may just be constantly in atrial fibrillation, which is sometimes okay, sometimes not. And then paroxysmal is it kind of comes on and attacks. And so you still would need to treat that with anticoagulation and potentially need to treat that with rhythm or rate control. Down here at the bottom, I said atrial flutter, essentially the same, ... And kind of what I mean by that is that it's not the same. It is a different entity, but for the most part, really, we treat it about the same as far as we'll need anticoagulation, we'll need rate or rhythm control. But as you can imagine, instead of just fibrillation or wiggling of the atria, with atrial flutter, it's like beating, but it's beating too fast, and there's still kind of an element of disordered electricity. Excuse me. With a flutter, I have kind of just anecdotally heard from cardiologists that those sometimes need more cardioversion for treatment as opposed to the medicinal treatment that we typically start with. So let's go back to, we kind of looked at these slides already, kind of just simple representations on that. This is from a 2020 article in the journal Circulation. It's just kind of a good infographic about kind of like risk factors for AFib and kind of the epidemiology of it. And so you can see there's 2.7 million people in the US, and that was kind of in between that time period. Very high incidence or prevalence of atrial fibrillation. Like it is the most common or arrhythmia that comes up, and you'll see it. Like if you've done any work with adult patient care, you'll see a lot of people have atrial fibrillation, whether or not that. And like in my line of work, you'll see them come to the hospital a lot, or you'll see them come in for other reasons, and they just have that diagnosis. So it's definitely something to be aware of and to know how to treat. And so let's see, so a couple kind of common presentations. Things that AFib can cause can really be anything, like chest pain, dizziness, all those things up there. And again, with what's going on, the heart beats too fast, it doesn't beat effectively, so they get effectively decreased perfusion to parts of their organ, whether that be the heart itself, leading to some ischemic chest pain, or whether that be their brain, and so they feel dizzy, they might pass out, like our patient had that we saw earlier. The kind of the heart failure exacerbation, of course, that too, like again, heart beating too fast, not pumping effectively, fluid will back up, and if they're predisposed or their ejection fraction is already pretty low, then they might show up with a component of heart failure exacerbation. And then also stroke, we'll talk about this more, but AFib raises the risk of stroke. And so some patients who present with either symptoms of a stroke or having had a stroke on imaging, workup will demonstrate that the likely cause was embolic from atrial fibrillation. So definitely something to think about whenever you have a patient presenting with a stroke. And then, some risk factors, kind of like what was listed before. A lot of different things can cause it, or at least contribute to it. I guess I don't have sleep apnea on there, but that is a big one that we see. Heart failure, I think it took me a while to kind of grasp the thought that as you have structural changes in your heart, either from dilated cardiomyopathy or from like heart failure with reduced ejection fraction, where your heart is starting to get enlarged. Anytime you have structural changes of your heart, you're just more prone to getting electrical abnormalities also, whether that's atrial fibrillation or whether that's like going into ventricular fibrillation. And so just something to think about, something that I didn't quite grasp for a long time, but abnormal electrolytes, calcium, magnesium can cause problems. Potassium, of course, if that's off or too high or too low, that can cause a host of problems. The illness that I have listed there, so that's really just kind of like anytime a patient's real sick in the hospital, they can start with, they can develop AFib, or if sometimes what will happen is that they are or are not very sick. They're in the hospital being monitored on telemetry, and then they develop AFib, and where they've already had it, like maybe a paroxysmal AFib that they go in and out of just occasionally, and since we're monitoring them, we find it. So sometimes having an acute illness will lead to development of atrial fibrillation. Sometimes just being in the hospital monitoring will kind of prove that out, even if their reason for their being there hasn't caused the AFib. So physical exam, things you'll find, kind of like we mentioned in the case study. So irregular heart rate, and they'll be tachycardic. Really, so you can have atrial fibrillation and not have the rapid ventricular response where the ventricles are beating faster than they need to. And so you might just have an irregular heart rate. And then again, people that are rate controlled, that are stable on medicine, but persistently in atrial fibrillation, that's probably what you'll find on the exam. And so, if they're tachycardic, that can be more serious and cause them more problems. The other things, like they might have those things, they might not. If they do have those things, then that's a little bit more concerning, that the atrial fibrillation is uncontrolled and needs to be addressed quicker than if they're just sitting there comfortable. So so workup listed here. So again, with AFib, it's disordered electricity, it's an arrhythmia, and so you get an EKG, and that's, you kind of find it or you don't. And so there's not a whole lot of there's not a blood test saying like, oh, this person has AFib, or they won't really mention it on test X-ray or anything like that. So really the EKG is the way to diagnose it and the way to find it. So kind of like we mentioned, and we'll look at a couple examples here in a second, but you will not find P waves. You might find some F waves, which are just because there's like multiple areas of depolarization in the atria, you'll get kind of like different wiggles in the baseline of the EKG. And so those are deemed F waves. Excuse me. So you might see those, but you won't see like the regular nice bump that is a wave. And the QRS complexes, they're going to be narrow because the depolarization is still happening from up above. So they won't be wide unless there's a bundle branch block or some other aberrancy going on in their electricity of their heart, but usually going to be narrow as far as the QRS complex goes. And kind of like I talked about, nothing else is going to be diagnostic of AFib. You might find that they are hypothyroid or hyperthyroid. You might find that they have their electrolytes off, but those are things that are peripheral, not necessarily going on. So a lot of times patients that come in with atrial fibrillation, especially if it's a new diagnosis, you do want to get an echo to see what is the structure of their heart, because like I mentioned, if someone has undiagnosed heart failure, that could certainly lead to atrial fibrillation, or if they have atrial fibrillation, that could lead to them having heart failure if their heart is stressed for a long enough period of time. So occasionally on the echo, if they're excuse me, still in AFib, then it'll say like, yeah, AFib noticed at rest, but they might have some dilations, some structural changes, but not something that's necessarily going to be there. So again, you could consider a chest X-ray, angiogram, stress testing, really for that. So again, someone who has a new diagnosis of atrial fibrillation and there's not something else that seems to be the cause. So there's not like their potassium isn't crazy low, or they don't have like a large pulmonary emboli leading to strain on the heart, leading to AFib. You might want to consider like an ischemic workup to see if they have any, have had ACS, or if they have significant coronary artery disease. And of course that will happen with consultation of a cardiologist. And so that'll kind of make that decision for you. But something to think about too, especially if some of you guys do go into cardiology, like new onset AFib may deserve an ischemic workup. And so that can be an angiogram or exercise stress testing, which are kind of the modalities we use for that. Outpatient monitoring. So if someone's complaining of palpitations and all their workup's been normal in the outpatient setting, then you could, the Holter monitor, a Zio patch, those are things that you could do to monitor their rhythm for longer. Holter monitor is kind of what I learned about when I went through training. It's basically like a mini EKG that sticks to their chest, and they have to wear it for a period of time. Kind of bulky, kind of annoying. It's basically the size of like the telemetry boxes that you guys, if you guys have seen those in the hospital. And so you imagine like slipping that around for a week. That's going to be really annoying to the patient. So the Zio patch, that's a newer thing, but it's much smaller, like really like about the size of your phone, maybe a little bit smaller depending on the kind of your phone, but it sticks to your chest. It's also a mini EKG. And so it's just, it sticks to their chest, and so they can like shower with it and everything. It's just a little bit more convenient. And it'll stay on for about 2 weeks, and that'll just a lot more information for someone to potentially catch episodes of atrial fibrillation, especially if they can say that the time they had AFib was the same time they had the palpitation symptoms. And so again, our patient got sent home on a Zio patch, and so that's something to consider for patients leaving the hospital, or again in the outpatient setting if you're thinking that AFib or some other arrhythmia may be leading to their symptoms. You can get that checked. So this is going back. This is the same EKG that we looked at earlier, and so just kind of pointing out some of the findings that we talked about. And so yeah, he's got these F waves over here. Again, that's just kind of wiggliness of the baseline because of the fibrillation of the atria. And then of course, as you can see, that the heart rate's pretty irregular. So another example, I think this just came from either Life in the Fast Lane, which is an great online resource, or some other EKG library, of which there are lots of them. So if you want more examples, there are ways to get them. But so as you can see here, like if we were to systematically approach this like before, I'll get that out of the way. So one is about isoelectric, so it's not necessarily positive or negative, and so he may have a little bit of right axis deviation, but it's not severe. AVF is definitely positive, and so that's good. Heart rate, so again, yeah, it's a little bit irregular, so it's kind of hard to say, but generally kind of doing the counting down thing, so 300, 150, 100. So that, it's about probably a little bit tachycardic, 300, 150, 100. So he's a little bit on the tachycardic side, but it's not terrible. And then looking for P waves. Oh, again, I don't know that I really see any. I see a lot of bumps. He may actually have a flutter. Is kind of what that looks like a little bit, but I don't see any definitive P waves in front of every QRS or anything. QRS itself looks okay to me. Our wave progression looks okay, and then as far as the ST segment, it looks like he may have some inverted T waves, maybe here. It's kind of hard to say. Is maybe just a change from. Yeah, so maybe some inverted T waves here. It's kind of hard to say. It'd be nice to look at an old EKG and see if those were present also there to see if that's any concern for ischemia. But yeah, so we kind of talked about F waves there, maybe a little bit there. Here's another example. This is another patient that I was taking care of in the hospital. So we have, this is just a telemetry strip. So this is kind of what you might see if you come to the Cox system, and probably most hospitals, and kind of how they have things set up. So as you're looking at this here on the left, you don't see it doesn't give you any of the leads. I guess they're listed over here. I don't know why I couldn't get that in the picture, but you can see pretty tachycardic. It doesn't have the boxes lined out, but I mean, that looks pretty fast to me. Maybe some irregular of the baseline. I don't see like consistent P waves in front of each QRS. I think these are just the T waves there. And so it might be hiding something. It'd be nice to get a full EKG to look at that. But up here, I don't see any P waves. Down here, really not sure that I do. And so right at this point, and then over here on the right side, so she's got a PQRS, PQRS. So she went back into sinus rhythm. So this was a patient, I know we didn't talk about her earlier, but she had actually come in for headache and was found to have meningitis. She had high blood pressure and maybe not a lot of other medical history. And so she's someone that either because of the stress of the acute illness, she was also septic when she came in. So either because of the stress of the acute illness, or she had AFib, like paroxysmal AFib at baseline, and just because we were monitoring it, we found it here in the hospital. And I think it may have been more so the latter, because what happened is that they called me at night and said, hey, her heart rate's really fast. What do you want to do about it? And so we got an EKG, showed it at AFib, and then I was going to go talk to the patient, talk about like different options we needed to do. And before I even did anything or added anything, she just spontaneously converted to sinus rhythm. And so she, so that's why I think she had more so paroxysmal atrial fibrillation. So yeah, so that's her. Let me maybe just kind of pause there. This is maybe about halfway through, maybe a little bit over. And so any questions on what I've talked about so far? There's probably some things that could bear with clearing up. It's fine if there's not any questions, but I'll just pause for a little bit and see if you guys need anything further clarified or have specific questions, and then we can jump into treatment. All right. There's no hand raising or anything. So, okay. Well, yeah, we'll march right out. If you guys do have questions, feel free, of course, to ask, or again, reach out to me later on. So treatment, kind of different, couple different boxes to fit treatment into. And again, then this gets a little bit into the whole like grayness that is medicine, and less so the black and white. Because I think when I went through, I learned like you're just kind of like straight up and down. You're doing rate control, you're doing rhythm control. You're going to need to anticoagulate them. And that, you know, there's just kind of some crossover. It's like if there are different buckets of what to do to treatment, rate versus rhythm kind of has like a connection, like a tube connecting at the bottom. And so things will kind of flow from one into the other. Sorry. So yeah, so rate versus rhythm, it is kind of a helpful paradigm for talking about, even though there's some crossover. And so we'll kind of start with that. So rate control, and this is typically the route, used first, especially in treatment naive patients. We'll talk about some indications, one or the other, but so you want to slow down the heart rate. Again, if you're thinking about what's going on with the atrial fibrillation, the atria aren't beating well, the ventricles are taking over, so then they're beating too fast, and so you need to slow it down, and that way as you slow it down, they will be more appropriately and stronger, and so you should get resolution of some of those symptoms. So beta blockers and calcium channel blockers are kind of workhorses of this class. There's a couple different ones that you can use. Really, any beta blocker is going to slow the heart rate down some. So selective ones may be a little bit better for not reducing their blood pressure too much, but that is a definite side effect that you can have. Yeah, so they both work by actively lowering heart rate. Depending, so kind of the ones that I've used most often for this are diltiazem, kind of like was mentioned in the first patient, metoprolol or esmolol. So a lot of those kind of the benefits are that you can do oral doses or you can do IV doses. And so that just makes it versatile. And so if you use a medicine and hey, it's working for the patient, great, I'll just switch it over to an oral medicine. So you don't have to stop one therapy to try another therapy, basically, when you switch to oral medicine. So diltiazem and esmolol can both be given as a continuous drip, which is just something to think about too. So diltiazem, let me back up. Diltiazem and metoprolol can both be given as IV pushes, where you just have the nurse push a whopping dose of it. Sometimes that'll work and that'll control their heart rate, and then you can just switch over to oral medicine and let them go home. Sometimes that won't work, and so you need additional treatment. And so if you gave diltiazem and it did work, you can continue with just a diltiazem drip. For metoprolol, if you give the IV pushes, and a lot of times that will help, and sometimes it'll flip them just back into the normal rhythm or keep it controlled. If that doesn't work and you can't use a calcium channel blocker, then esmolol is a continuous drip beta blocker, and so that can be used for treatment instead. Verapamil is one I'll just mention. It's one you can use. It seems like the EMS stocks that more than the others, and so a lot of times they'll come in having gotten a dose of the verapamil. Just mentioned too, so of course they can cause low blood pressure. We'll use calcium channel blockers to control blood pressure, so not a surprise there. So calcium channel blockers will decrease the inotropic effects of the heart, or decrease inotropy. And so if they have heart failure, or you think they might be in a heart failure exacerbation, you really don't want to use a calcium channel blocker because that's going to potentially make things worse. And so you're really obligated to use either a beta blocker or rhythm control with amiodarone or something else. Digoxin is an older medicine. We used to use it both for heart failure and for Afib. I think it's still got a little bit of a role, but it's just not used as commonly, in part because there's a narrow therapeutic range. You can cause some problems using it. And so digoxin is one that I actually have used not a decent amount, but if patients got a low blood pressure, but they're not like imminently crashing and needing a higher acuity treatment, sometimes digoxin can be a helpful adjunct to what you're already doing with either the beta blocker or calcium channel blocker. Or if the patient's already on it at home, then of course you can continue it, and that should kind of help control it. Digoxin is another medicine that you can give IV or orally, and so kind of versatile from that standpoint. So those are rhythm. Kind of thinking about rhythm. So amiodarone is kind of the workhorse there, one we use the most. It is also IV versus orally, and so you can give that as a push or a drip, or you can give it as an oral pill. Yeah, so it is an antiarrhythmic. Problem with that one is that we don't like to use it for a long period of time because it can cause adverse or fibrosis. They can cause thyrotoxicosis or liver disease, and so you really don't want to use it for a long time. And most patients that are seeing a heart doctor who prescribes that are getting that kind of weaned off, but it can be useful in the short term, especially that's really where I see it working in the hospitals, using it short term. So something to think about. A couple other rhythm control strategies. Of course, there's a couple other more specialized medicines: flecainide, difetilide, sotalol. Those are the ones that I've seen. So there's a lot of antiarrhythmics. And again, and that kind of gets into there's like class 1, 2, 3, etc. And so I don't know all the ins and outs of these ones, but definitely could be looked up or talked about if you have further questions. Cardioversion is another way to obtain rhythm control. And that's what it sounds like. You're just shocking the heart, kind of pauses everything, ideally gets it start back beating in a normal rhythm. It's nice, it's quick, It's necessary if they are unstable. And so if their blood pressure is falling, which prevents you from using beta blocker, calcium channel blocker, you don't want to wait for a medical antiarrhythmic to work. They're crashing in front of you. You just need to shock them. And so that's something that can be done emergently. The other side is that it can be done just to fix the rhythm if they don't want to take medication, or if like the medications aren't working super well. If that's the case, then you need to make sure that they don't have a blood clot, which could lead to strokes if they have their rhythm suddenly restored. And so requires either known existence of less than 48 hours, which is hard to do outside of the hospital setting, or it requires 4 weeks of anticoagulation. A lot of times what the cardiologist will do is they'll bring them in, they'll do a transesophageal echocardiogram to look and make sure there's not a blood clot, and then they'll proceed with the shock if there's not a blood clot there. So different options as far as the rhythm goes. And kind of like I talked about, there's crossover. Just kind of want to mention too, like I think I already talked about this. Patients can have spontaneous conversion, which is what we talked about with the patient with meningitis. Either strategy may eventually fail, and so it's certainly possible that you start one thing, it's not going to work, so you go to your next thing in your toolbox, and then I will be reaching out to the cardiologist, or you may be getting a call from a hospital doctor if you are in the future a cardiologist. New research, I just wanted to mention that it seems like they're constantly, AFib is very common, and so you're going to get a lot of benefit if you study it. You're going to help a lot of people, and so they're kind of constantly talking about different ways to think about stroke risk, or here are some new treatment strategies. This is where these strategies are effective, and so constantly evolving field, as is the rest of medicine. So another kind of bucket for treatment, which quote unquote treatment, because you're not fixing the AFib if you're thinning the blood, but atrial fibrillation raises your risk of stroke. And the pathophys there really is that as the atria are not beating well, blood congeals, forms a clot, and then as your ventricles contracted, that clot can get showered out into the rest of your body. And so kind of the way to decide if anticoagulation is needed or not, there's the very helpful CHADS 2 VASC score. And what I do for this, as opposed to memorizing it, is look it up every time. In the kind of the nature of my work, almost everybody qualifies for anticoagulation because they're sick enough, have enough else going on. But and that's kind of determined by age of the patient, their sex, their history of hypertension, heart failure, prior strokes in the past. And so if they have enough of those going on, then the risk of stroke is kind of outweighed from the risk of bleeding, and so you'd want to start them on an anticoagulant. So this is an area too where kind of new research is coming up, but used to use warfarin. It's an older medicine, it's cheaper, and so it's a little bit harder to monitor though with the INR. And so newer medicines like apixaban and that sort of thing, or Eliquis, Xarelto, those are being used now more frequently because they require less monitoring, and they're starting to get better paid for by insurance. So a patient with new diagnosis of AFib needs to at least have this conversation, may need anticoagulation based on kind of the patient's lifestyle and the risk factors. So just wanted to mention some of these more specialized things. These are things outside of my wheelhouse for sure, but things that could be used for atrial fibrillation. And so ablation, effectively, they'll go in and burn out what they think is the offending electrical pathway. And so that's very specialized. They'll go in a specialized heart doctor. So an electrophysiologist will have some training in that. They'll kind of put a catheter in, find where the impedance is high enough or something, and then they'll burn it out. So it can be pretty effective. And also, like, again, if a patient wants to get off medication, this might be a way to get them off it. Excuse me. May's procedure is effectively ablation, but it's through surgery. And so I don't know that it really is that common anymore, and really probably only at tertiary care centers like in St. Louis or Kansas City. Watchman device. So that's an interesting, again, newer kind of development, but basically, so again, with the risk of stroke coming from like blood clots in the atria, what they do is they basically go in and kind of seal part of it off, put a kind of a basket there to catch any clots that develop. And so that reduces their stroke risk. It's not inferior to warfarin, which again was the gold standard for anticoagulation. And so it's something to think about if a patient either doesn't want to be on anticoagulation, or if they have like a history of severe GI bleeds or something else that would preclude the use of anticoagulants. So yeah, so that's kind of the, I know, I guess we're running a little bit low on time, so sorry about that, but that's kind of that on atrial fibrillation. Did want to shift gears a little bit and talk a little bit about kind of cultural competency. This is just something that I think is really important. Kind of again with the twist in the patient one case, you can see where it's not hard to imagine that being understanding of other people's culture, and that's much deeper than just language, that really can affect how well they get care or receive care. And so a lot of different ways to define culture and the competency thereof, but basically, being respectful or at least knowledgeable of all the different facets of a person's life. And I think that's really important in medicine. And we'll kind of get a slide kind of on that. So a lot of different reasons why that would be important. This is a list that I got from an article, I think out of the AFP put out. And so some of these are a little bit like, sure, I guess so. Decreased likelihood of malpractice claims, gain competitive edge in the marketplace. Sure, if you're taking good care of people, they'll want to come see you. But really, like, the goal of medicine is to keep people healthy. And so kind of my thinking of why it's important to be culturally competent is because as a physician, you're either trying to increase a person's baseline health or fix a disease they have. And a lot of that involves talking and educating the patient about what's going on. In order to educate a person, they have to receive the information. And for them to receive the information well, it's got to be shared in a way that's understandable. And so a lot of times that involves being culturally relevant. And that's either, of course, using the language that's preferred by the patient, excuse me, maybe presenting things or making things understandable in a way to them, as opposed to just like, here's the black and white nature of what's going on, this is what we need to do, but kind of talk to them about like what's important in their life, why treating this medicine, using this medicine, treating this disease will be helpful for their goals of care. And so I think it's just something that is really necessary. It's more than just using a translator. So I mean, you walk in a room with a translator and that'll be helpful for crossing some barriers, but there's still going to be some paradigms or worldviews that the patients have that need to be crossed also. It's hard. It's not, I wouldn't say it's easy. It requires a lot of humility because you're going to be wrong about things. Requires preparation on some level and being a perpetual student, especially if you are in an environment where you're consistently seeing patients of other cultures, then you're going to need to kind of know what's relevant to them, be always learning and making mistakes and learning from that. There's some kind of list of suggested questions here. I won't read through those, but we can look at that later. Excuse me. A few examples of things that I feel like it kind of gave me pause before. And I've done some overseas work in a hospital, and so I've kind of actually run into some of these. But so like if you're doing a C-section on a patient, it's her like 4th or 5th. She has a lot of adhesions. It's kind of unsafe to continue doing C-sections. So patient wants a tubal ligation, you think could medically be appropriate. But in this culture, the male kind of makes that decision and they don't want to do that for whatever reason. And so that's something that, is difficult, something that is definitely not the American culture, typically. Amulets too, just like trinkets that they hang around either the neck, and I'm sure you guys have all seen like the kind of black, white, and blue one showing warding off the evil eye, something that, we want you to take this medicine or get this vaccine. Oh, but we have this amulet and this to protect my child from disease. And so one that I ran into recently was a patient that needed translation in the ER, older gentleman. A lot of times what will happen is that if a family member is present and can speak English fine, then they will use that person as a translator. And that's certain times that's probably okay. It's okay if everyone's comfortable with it, but a family member translating may not have the medical verbiage that we do in English or in their native language. And so you're not guaranteed to get like the best translation. Also, there's all of like HIPAA and what the patient needs to know or doesn't want the family member to know. And so this was kind of brought up, this older gentleman who does not speak English had his 10-year-old grandson in the room, and they were using that to translate. And so that's just kind of probably shouldn't happen. That child probably does not have all the necessary qualifications to translate well. So I think that's kind of the end of my talk. I just kind of put the objectives up here again. I think we've hit on all of these. Hopefully they've been in a way that's been understandable for y'all as I try to transmit that information. And so yeah, reference slides just for you guys to see. So that's all I had. I appreciate you guys letting me speak to you. I've got a number and my work email here. And so if you guys have questions, I guess if you guys have questions now, we can certainly talk about it. Or if you guys have questions that come up later about atrial fibrillation or hospital or family medicine or anything over the next, gosh, 7 to 10 years as you guys go through training, please don't hesitate to reach out. But yeah, so that's all I've got. Again, if there are questions, I'm happy to talk about those. If there's if not, then I guess you guys are probably free to go on with whatever's next in your day.